Women tend to live longer than men. Men are less likely to go to the doctor when they need care. Women are less likely to be believed when they tell a doctor they're experiencing significant pain. Men are 4 times more likely than women to die by suicide. This is Unsettled, a podcast from Iowa Public Radio, and this season we're minding the gender gap. I'm Charity Nebbe. On this episode, gender-based disparities in healthcare. Later in the show, we'll talk about how these disparities are impacting Americans every day. But we're going to start with a look at how we got here. The history is important. Dr. Laura Hirschbein is a psychiatrist and historian with the University of Michigan and vice president of the American Association for the History of Medicine. Laura, welcome.
Thank you so much.
Now, we know that the roles of women and men have evolved over time, and our traditional roles in society are a part of the gaps in healthcare that we see today. At the beginning, men were far more likely to be doctors, so that's part of it. But also, the way that women were seen in medicine early on was primarily in terms of reproduction. Tell me more about that.
Well, the standard way of viewing the human body, certainly by physicians in the America in the 19th and 20th centuries, had to do with focusing on what was considered standard. And the standard body was really a white male body of a certain size. So the 70-kilogram man was sort of the standard, and everything else was a deviation from that. And the assumption was that if you just focused on that, that would tell you everything you needed to know about physiology and biology, except for reproduction. And that was where women were different. And so what that meant is that women were seen primarily in terms of their reproduction, because that was the only way they were different or assumed to be different from men. And that could change how they were seen, both in terms of their bodies, but also what that meant for their bodies. So, for example, in the late 19th century, a famous Harvard professor announced that women were so consumed by the need to maintain their bodies for reproduction that they couldn't be educated on the same basis as men. They had to be segregated and kept in a safe space so that they wouldn't expend all of their energies that were needed for reproduction. That was his view. That was viewed very, very differently by other people at the time, including a large number of women physicians. So there were actually a significant number of women trained to be physicians in the 19th century. The first woman graduated from U.S. medical school in 1849, and there were medical schools specifically designated for women in the 19th century. So in the 19th century, there was a lot of willingness to really kind of think about women and men, and there was still a lot of focus on reproduction, but there were people willing to kind of grapple with the issues. By the 20th century, most of the physicians were men. The women's medical schools closed down, and the idea again that women were defined solely by their reproduction really kind of took hold and took over.
Tell me a little bit about when clinical trials started, because clinical trials are also an important part of this story. That standard 70-kilogram man was pretty well represented in clinical trials, but they didn't really start until after World War II, right?
Right. While there definitely was research that people were doing and calling it research. I mean, they believed that it was cutting edge science at the time, in the late 19th and even early 20th centuries. Standardized clinical trials, the idea of really kind of thinking about controlling for chance, controlling for placebo, came about after World War II with the rise of pharmaceuticals. And so the pharmaceutical industry that we think about now really arose after World War II. And the original clinical trials were intended to see whether these substances, these drugs, did anything, and if so, what did they do? Many of the clinical trials really, in a few decades right after the war, were sort of more of a, let's try this and see. And so people were given drugs, sometimes with informed consent, sometimes with things that we might not consider so informed or so consensual, but they were given drugs to sort of see. The intent was generally to help. But most of the drugs outside of the mental health sphere were tried on men rather than women. There weren't clear policy directives. It wasn't as though somebody was regulating the research at the time. That didn't come until much later. But in general, women were not selected for trying drugs, especially drugs that were very important right after the war, things to test lowering blood pressure, lowering cholesterol, helping with diabetes. Those were big drugs in the post-war years, and those trials were almost exclusively done in men. Up until really the 1990s, people didn't talk about it or think about it. It was an office in the early 1990s at the Food and Drug Administration and at Health and Human Services that pointed out that actually we didn't know very much about women because women were not included in these clinical trials.
The 90s were not very long ago. That's also when you went to medical school, and you could see the reaction to how we had studied medicine when you were learning about medicine, right?
Absolutely. We learned medicine really in stereotypes. It's not intended to be restrictive stereotypes, but we learn sort of typical cases. And so we learn examples and we learn kind of ways of pattern recognition so we can quickly assess whether something might be happening. And when I was in school, there was a very famous atlas of illustrations that was helpful in anatomy because when you look at a cadaver, sometimes it's not quite so pretty. It's hard to kind of pick apart what exactly is going on. So there was this encyclopedia of illustrations that was supposed to help students, and included in that illustration book was a classic picture of a heart attack, and it showed what you might expect from the 1950s or 60s. A businessman who clearly had been traveling with a cigarette falling out of his hand, coming out of a pub where he was probably not eating very well, carrying a suitcase. So he'd been traveling, clutching his chest and dropping things with his arm because his left arm was numb. And that was the way we learned about heart attacks, that they happened in men, typically middle-aged men who were in stressful circumstances, who smoked and didn't eat well. And that was kind of the classic view. And it was a kind of a revelation to many of us who were trained like in the 90s and the early 2000s that heart disease is actually extremely common in women, and it looks different. We didn't learn the classic way it presents in women. We learned the classic way it presents in men.
So there was that disparity, but also we already talked about how women really were thought about in terms of reproduction. Women who develop heart disease tend to do it after their reproductive years are over. Is that part of the disconnect as well? That since women weren't reproducing, we weren't thinking about how they were reacting and aging?
I think that's part of it. I think also for many years, reproduction itself was so dangerous to women's health that they tended to the women who lived long enough to have heart disease, that was one population. But a large number of women would die in childbirth or in their reproductive years. So there have been some changes in terms of how women live their lives. But I think because women didn't necessarily manifest with the same presentation as men, people sort of assumed that their reproductive hormones were protective, and there's still very much an assumption that women's hormones are what keep women's reproductive hormones are what keep women from having heart attacks, which has led to the assumption that women just need more hormones, which turns out is not quite accurate for many women. For some women, getting hormones like after menopause can be a good thing, but for some women, it can increase the risk of cancer, which is a whole different topic of conversation. So it's just more complicated than I think people have assumed.
So we've talked a lot about the disparity in how medicine developed with regard to physical health. Mental health was a really different story when it came to men and women. Why was it different? How was it different?
So a larger percentage of people who were institutionalized in state mental hospitals in the first half of the 20th century were women. A larger percentage were women. Most of the mental health care that took place in this country up until really the 1980s and 1990s, most of the healthcare took place in large state mental hospitals. There's a statistic in 1950 that half of the hospital beds in the United States were actually psychiatric beds. And there were something like 500,000 or more people institutionalized in hospitals. It was a vast population, and it bears almost no resemblance to our mental health care system now. But that was the system of care, was in state mental hospitals. And more women than men were in those hospitals for a variety of reasons. Some of it was because they would have been the caregivers. So women would have been the caregivers. And so they were able to care for men at home. Some of it was some men were more likely to be in prison or in hospitals for alcoholics that it still existed in the middle of the 20th century. So at the time that psychiatric medications were beginning to be experimented with, and that was when pharmaceutical companies came up with compounds that probably would help people by helping them relax or helping them calm down, or really before anybody knew kind of how to define depression the way we do now. Pharmaceutical companies partnered with physicians who were working in state mental hospitals and passed out the medications and said, here, let's try these and see what happens. And so for the first really several decades, 3 or 4 decades, when psychiatric medications were first introduced, they were tried in populations that were more women than men. And you could see this if you look at the publications of psychiatric medications in the like 50s, 60s, 70s, 80s, even through Prozac in the late 1980s. More of the subjects who were given these medications to try out to see what happened were women rather than men. And that was entirely opposite to what was happening in the physical health field. But in mental health, these were the populations who were getting tried with medications. So it started off with giving people, mostly women, the medications to see what would happen. And these started with chlorpromazine or Thorazine, imipramine, which is an antidepressant, and other medications, again, through the 1980s and 1990s. And then it was initially, let's just try it and see what happens. And then as they continued to evolve clinical trials to do things like have placebo controls, meaning giving some people sugar pills and kind of seeing how that compared with people who were taking active drug, they continued to recruit more women. And so the greater numbers of women, particularly in trials of the medications we think of now as antidepressants, help to even shape how we understand depression as an illness.
And I want to pick up on that in just a moment. We're going to take a short break. I am talking with Dr. Laura Hirschbein, a psychiatrist and historian with the University of Michigan and vice president of the American Association for the History of Medicine. This is Unsettled from IPR News. This is Unsettled from IPR News. I'm Charity Nebbe. We are talking about the gender gap in healthcare. In a few minutes, we'll talk about how gender-based disparities in healthcare impact Americans every day. Right now, we are looking at history. With me is Dr. Laura Hirschbein, a psychiatrist and historian with the University of Michigan and vice president of the American Association for the History of Medicine. And Laura, just before the break, we were talking about how with so much of physical medicine, the focus was on men in clinical trials and elsewhere. When it comes to mental health, the focus was really on women. The focus was on women because the majority of people who were in psychiatric hospitals when we started introducing medications for mental health care were women. So these medications were tried on women. And we see that shaping our ideas about mental illness for men and women today. How do we see the effects of that?
So when the medications were tried in populations of women, what that meant was we knew kind of what worked by which patients got better. And so by looking at who got better with which medication, what psychiatrists did was basically work backwards and say, these must be the symptoms that we need to look for when we're diagnosing depression, for example. We're basically retrofitting what the effect of the med to understand the diagnosis. Prior to 1980, there were no criteria for major depressive disorder. There were actually no criteria for any specific psychiatric disorder. That was all created with DSM-3 that was published in 1980. And so the trials of medications that became known as antidepressants those trials actually helped make up what the diagnosis of depression was. And I think that you can really see that in what the diagnostic criteria for depression that have been the same pretty much since 1980 through DSM-5 that was published in 2013. A majority of the symptoms are feeling states. Patients endorse feeling sad. They endorse feeling not motivated, having difficulty concentrating, sort of thinking about how they're concentrating. They endorse feeling a lack of motivation. They sometimes feel guilty. And so these things are things that were much more likely to be endorsed by women, certainly in the 1960s and 70s when these criteria were being elaborated. And it's really striking because in the early 2000s, the National Institute of Mental Health put out a publicity campaign, an educational campaign called Real Men, Real Depression, that was about the fact that too few men were diagnosed with depression, partly because they didn't endorse the symptoms. A lot of the things that they described were not in the DSM criteria. And they complained about things like irritability. Irritability had been a symptom included that was in discussion in DSM-3 and got taken out for a revision in 1987 because the person who wrote DSM-3 decided that it probably fit more under bipolar disorder rather than depression. But in the 90s, it became very clear that men can have very different symptoms than women. In the mental hospitals in the 60s and 70s, men who had substance use disorders, especially alcoholism, were excluded from trials with antidepressants and sort of assumed to have something different. And yet, one of the things we know about men in depression is that it often goes along with alcohol abuse, alcohol dependence, basically alcohol misuse. And so these things kind of go together in a lot more commonly in populations of men than they do in women. And so it tends to be that it's not hard for women to get diagnosed with depression, but it's much harder for men, which reflects the history of the diagnosis.
Right. And we see the consequences of that playing out every day now. So we'll dive into that further with our next guest. But before I let you go, um, today we see that the average American woman, the longevity is 81. For an average American man, longevity is 76, life expectancy. There is that significant gap there. When we look at things historically, has that gap been pretty sticky? Have women historically lived longer than men?
There's been a bimodal curve of women. There has always been a group of women who lived longer than the group of men, but the sort of larger numbers of women living longer than larger numbers of men is more recent. Again, since women started living past reproductive years, the sort of long history that people sort of assumed that men lived harder lives, that they had more stresses and strains, more things to tax them than women did, which of course anybody who has lived through the time periods knows that that's not especially true, that women certainly have worked as hard, done as many things as men have. And there are some people who speculate that women's bodies are built to withstand more stresses and strains. No, but nobody has any idea. But I think that the research around aging women has been really missing. This has been a complaint among gynecologists for a long time, that the focus on women's health has been so firmly tied to their reproduction that as soon as they're done with that, nobody really wants to think about them anymore. And so I think that we have lots and lots of questions, what seem to be very concrete differences between men and women that turn out to be maybe a little bit more complicated than that.
Well, it's fascinating. Dr. Laura Hirschbein, thank you so much for talking with me today.
Thank you.
Dr. Laura Hirschbein is a psychiatrist and historian with the University of Michigan and vice president of the American Association for the History of Medicine. We've been talking about history so far, but we're going to now move into how some of the gender disparities we see in healthcare that became part of the system affect us each and every day. So to start us off, Anita Raj is here, Executive Director of the Newcomb Institute and Professor of Public Health at Tulane University. Hello, Anita.
Hello. Thank you for inviting me.
It is wonderful to have you here. And before we bring our men's health expert into the conversation, I do want to start off with an area that primarily affects women, and that is maternal health care and reproductive care. Women were seen almost entirely as reproductive vessels in medicine, as we just learned a few minutes ago, for a long time. But the maternal health part of a woman's life, if that's something that she does, that's still a dangerous time for women in this country, isn't it?
Yeah, it shouldn't be the case, but being pregnant and giving birth can be a risk factor for death and is certainly a risk factor for certain health issues. And it's something that we in the United States don't focus enough on.
Well, maternal mortality in the United States is it's significantly higher than it is in other comparable countries. Tell me a little bit more about what we see.
Yeah, so we are among what people might call high income nations. We have among the worst maternal mortality rates in the world for given our level of wealth and access to healthcare. And it's quite striking. And we, it's not equal across all groups. We particularly see it in our Black communities. And there's a lot of reasons for this. One of the key factors that people will talk about are some of the chronic health conditions that can affect people into pregnancy, which are things like high blood pressure or diabetes. Certainly, that's an issue that we have here in the country, but a lot of people also feel that there are stressors that women face in the United States that may be unique, and particularly based on racial discrimination or racism exposures that can create stressors in the environment that impede your ability to have a successful pregnancy or create stressors that really compromise your abilities in birth. On top of that, we do see some levels of differential care, and that's something that we need to be focusing on more as well.
And I just want to underscore because obviously we're talking about gender primarily this hour, but we do have to talk about some of these other intersections in our culture and in medicine. I want to underscore the fact that maternal mortality is significant in this country, but it is even more significant for Black women. In fact, here in Iowa, a Black woman is 6 times more likely to die in childbirth or during that maternal period than a white woman is. That's a huge disparity.
It's a huge disparity, and it's in parallel to what you see with infant mortality. So this is something that, again, we have higher infant mortality rates than one would expect given the level of wealth and healthcare in the country, but it's not equally distributed. And so we're seeing it affect women's health. We're seeing it affect fetal health and development and infant survival.
We have had a lot of changes in reproductive health care in this country in recent years. And again, that is not static across the country. With abortion bans going into place in many states in the United States, that has led to situations where women who are pregnant and need reproductive health care, who have complications in their pregnancy, may need an abortion for their own health, are not necessarily getting them. Have we seen already that impact this maternal mortality rate?
I'm really glad you asked about that. So it's early yet to have the full scale of the data on the maternal mortality. We do know that the ban has resulted in maternal deaths. We don't know if it's elevated, but I can tell you this. States with the bans are seeing higher rates, a greater increase in infant mortality relative to the states without. And we know that this is because people are being forced to carry to term a situation with a non-viable fetus. That's not only compromising the risk for I mean, obviously the viability of survival for the infant is now compromised, but it's also putting women at greater risk. It's also harming their likelihood to be able to have births in the future. This is a really, really disconcerting situation. Additionally, there are some certain abortifacient drugs, so the kind of medications we might use for abortion, they're not only used for abortion, they're used for miscarriage management, and they're used for other health concerns as well. And so when we don't have good access to these things, we put women at greater risk, and women hemorrhaging can be contained by these kinds of drugs. And are we really not going to make those available when women need them? And it's not just punitive, in the sense like it might be not available, but it's punitive for providers that may provide it. And so what we're also seeing is that a lot of providers are here in Louisiana. We found that providers are less likely to see women in the first trimester care, and particularly women with complications, because they are concerned the position that they might be placed in. And you cannot blame the provider completely. You cannot blame a provider for this, because this could compromise their ability to provide care, and we have a provider shortage already. So we cannot afford to lose more providers. So this is an issue for medical care, and this is an issue for the lives of women.
So earlier you talked about with the higher rates of Black maternal mortality in this country, you talked about some of the reasons that might be. Why do you think that the rate is higher in the United States for maternal mortality overall than in other comparable countries?
It's a very good question. I think that a lot of people feel that the quality of maternal care is not where it should be, but also that the stressors that can be placed on women during pregnancy can be greater. We don't see in our society, I think, through the accommodations made for women in the workplace. For example, we're seeing a lot of pushback, for example, for things like remote work or, as women enter into a greater number of employment opportunities, the ability to participate in those opportunities in ways that would consider what their needs might be during pregnancy or around delivery or around, just even after you have children and you need childcare, um, the workplace hasn't been set up in quite that way, and that's not good for women. It's also not good for men. The idea of being able to take care of your family when you are a working parent is an issue for both women and men, and we are hurting people's health by not taking that into account better.
I'm talking with Anita Raj, Executive Director of the Newcomb Institute and Professor of Public Health at Tulane University. Let's bring our men's healthcare expert into the conversation as well. Derek Griffith is a professor of health equity and population health at the University of Pennsylvania and chair of the Global Action on Men's Health. And Derek, it's wonderful to have you here.
It's my pleasure. Thank you.
Now, earlier I said that we were starting with an area that primarily affects women. Of course, when we talk about maternal health care and reproductive health care and maternal mortality, men are involved in that as well because, of course, they are the fathers of these babies that are at the center of all of this. And you've recently been talking about the role of the father in Black maternal health. Tell me about that.
Yeah, I'm actually, as we're recording, at a conference, the eighth annual Black Maternal Health Conference. And this year, the theme is the role of fathers in addressing maternal health inequities. And it's here at Tufts University School of Medicine in the Center for Black Maternal Health and Reproductive Justice. And it's 2 days of really focusing on how do we better understand the roles of fathers and what roles they can play in addressing these issues.
And just very briefly, what are people talking about? What are you learning?
So everything from, often the fathers have a unique role in being able to see the mothers and expecting the new mothers on a daily basis or on a regular basis, and they're uniquely positioned to be able to monitor their health, their well-being, their behaviors, and see if there are things that they're doing that are not in their best interests. Everything from depression to, are they being active enough? Is weight gain, something that is concerning, either too little or too much? All kinds of other things that they can sort of play a role in. The other thing that we've seen with a lot of the folks here has been significant amounts of policy advocacy around trying to get better maternal health care across the continuum of services that women need, because it does, and how fathers have been really committed to that. We sort of treat it or talk about it or tend to frame it as though, as you mentioned, as though it's a women's health issue, but it is really a family issue. It is really a larger community issue, and men do play a part in that and are really committed to making sure that women do have healthy lives.
We need to take a short break. With me is Derek Griffith, a professor of health equity and population health at the University of Pennsylvania, and Anita Raj, executive director of the Newcomb Institute and professor of public health at Tulane University. More in a moment. This is Unsettled from IPR News. This is Unsettled from IPR News, and we are minding the gender gap. On today's episode, we're talking about gender based disparities in healthcare. With me, Anita Raj, Executive Director of the Newcomb Institute and Professor of Public Health at Tulane University, and Derek Griffith, Professor of Health Equity and Population Health at the University of Pennsylvania and Chair of Global Action on Men's Health. Derek, I want to talk about men and healthcare because we do know that men often don't go to the doctor when they should be seeking healthcare. How big of a problem is that?
It's fairly significant, but it's not we have to realize it's not necessarily the leading cause of death or the leading cause of men's roles in having a shorter life expectancy than women. It's certainly something that's important, but we know that the majority of things that lead to premature mortality, lead to having shorter life expectancy, poor quality of health overall, are really things that happen outside of the doctor's office. So we do have to sort of put it in that context. The second part is we do see that it is important because a lot of times when I've talked to men, they will be proud to say that they're healthy enough to have not been to the doctor in 10 years. And I'm like, well, how do you know that you're healthy enough? How do you? And so one of the things with men going to the doctor has been that they don't necessarily understand what are they supposed to get from going to the doctor. They will feel like they're getting often lifestyle advice and other things from the visit when they feel like they already knew that information before they went. They knew they needed to lose weight before they went. They knew they could eat healthier, be more active, and those kinds of things. What they have seemed to want and feel like makes their visit beneficial are some of the tests that you get that identify things that you can't see just by, how do you feel and how do you look. And so I think it's been some of those critical things that have been missed in visits when men go to the doctor, and translating that into what are the things that they care most about in terms of their ability to fulfill different roles, ability to do their jobs, the ability to do things that are important to them, the inability or the way that we haven't connected the information you get when you go to the doctor to the things that a men most see as most salient to their daily lives. um, that's where there's been a potential gap that we can help to fill in the medical space.
Okay, so the way we communicate with men about going to the doctor. But I mean, Anita, we were just talking about maternal health care. And so women kind of need to go to the doctor more regularly during their reproductive years, whether that's just to have access to birth control or because they are reproducing and they have this relationship through their prenatal care and postnatal care. I mean, are women more likely to go to the doctor because we're just in the habit of it?
Certainly there's a lot more support around childbearing to encourage you to go to the doctor. It's recommended. People talk about it. They ask you questions about it. So it's like we would talk about it as a social norm. But preventive medicine, as you age, it's equally important for women and for men. There's a lot of as Derek had mentioned, there's a lot of scientific evidence that just suggests that there's these ideas about, oh, I'm strong, I'm healthy, I don't need to go to a doctor, and that are kind of rooted in ideas about being a strong man that maybe women don't feel that they have to adhere to in the same way. So the idea that there might be an issue, and so that we notice it and may be more comfortable going because the idea it's not perceived as a sense of weakness is there. But as you've said, it kind of becomes this other issue, which is then there's skepticism about if that medical need that we're showing up for is actually legitimate. So, that can become a problem for us.
For sure. And so men may not go to the doctor, but when they do show up at the doctor's like, oh, this must be really serious. If this guy showed up, I am obviously stereotyping here, but you're saying,
Yes.
Anita, that
but yes, it's a stereotype, but stereotypes are sometimes rooted in reality.
right. And so women show up at the doctor and say, I'm having this problem. And because they're a woman, they are less likely to be believed.
That happens. I mean, what we definitely are finding is that there's an increasing shift. And one of the interesting things that's happening in medicine, medical care broadly, is that You are increasingly having more women go into medical school and graduating. You have more women who are the frontline medical providers. So a lot of the research that we have, it's somewhat dated. So absolutely, that was historically the case. But this may be shifting, and it's something that we're going to have to watch as more women providers are there. Maybe you won't see some of the skepticism with women. I don't know what that's going to mean in terms of men coming in for care. There's studies that show that men are more comfortable going to women for support or for need, for if there's a need. So maybe there could be more comfort that comes from going to the provider, if there's more women providers. I don't know. It's something that we're going to have to watch for.
Very interesting. And Anita, I know that sexually transmitted infections has been a part of your research as well. Do we see a gap in healthcare for STIs as well?
Yeah, so one of the big issues with STIs, I mean, I live in Louisiana. We have a very, relative to the rest of the country, we have a particularly high rate of sexually transmitted infections. And some of the most common are things like, syphilis, gonorrhea, chlamydia. Chlamydia, for example, is a situation where women are going to have the symptoms, men may not have the symptoms. They're likely to be asymptomatic. So women will go in to get care where men wouldn't. And so if you don't know that if you don't have the symptom, then the likelihood that you could potentially pass that disease on is now greater. So you can see some differences in detection for women and men for that reason. Also with women, you've got a risk of transmission. So, if it's syphilis, for example, like we worry about the transmission of the syphilis to the baby. So for that reason, there's a lot more testing of women that can be going on.
And I do want to just reiterate again that we need to also think about other factors in here. Derek, when we talk about, okay, men not going to the doctor, not necessarily getting help that they need in a timely manner, we also know that there are a number of diseases that are far more likely to affect Black men or men of color in this country as well. That's an important part of the conversation.
Absolutely, absolutely. And I did just want to pick up one of the things that in the transition that Anita was mentioning, Dr. Raj was mentioning, is that screening for particularly sexually transmitted infections isn't necessarily part of a regular visit for just like a well person visit, certainly not for a well man visit. So, unless you usually ask for that, those are not things that we would check and screen for, particularly once men reach into, say, middle age. Maybe like something that we would do more commonly in adolescence, but not something that you would typically do in middle age.
I want to shift the conversation to mental health care. And we heard earlier on that mental health research was focused primarily on women in the early days of mental health research. And that has led to this sort of stereotyping of what depression symptoms look like, being more similar to how depression looks in women. Derek, there are other reasons that men who need mental health care may not seek it or may not get it. What are some of the other factors?
Well, let's start with actually, the diagnosis of things like depression. One of the things that I and colleagues did some years ago, Lisa Martin is my colleague who led the study. We looked at depression symptoms and added in symptoms that sometimes men may be more likely to express. As opposed to saying that I'm sad or depressed, they may be more likely to say that I'm irritable, I'm having anger outbursts, those kinds of things, more so than saying that they're sad and depressed. If we include even things like increased substance use, those kind of factors. Typically, men are diagnosed with depression at about half the rate of women. When we included those types of symptoms, we actually saw the gender gap go away. My point in mentioning that is that we know that given men's rates of substance use, dying by suicide, and related factors, that there's something that we're missing in how we identify men who are in need of support services and attention. And it's not being captured some potentially by the way that we're diagnosing men with particularly mood disorders, but mental health issues in general.
That's so interesting. And I have wondered, I mean, is it related again to go back to men not necessarily asking for help or going to the doctor when they have symptoms? You mentioned substance abuse. Are men far more likely to self-medicate for a mental health disorder?
Absolutely. Men have higher rates of whether it's, tobacco use, different types of substances and so forth, as a way to cope with that, and we see it as culturally appropriate or gender appropriate to do that, and so we do know that those kinds of things are far more common.
You also mentioned dying by suicide. And men, I think the statistic is that men in this country are 4 times more likely to die by suicide than women. What do we know about why that happens?
So this gets more complicated. So I definitely want to bring Dr. Raj back into this. My understanding is that women may make more gestures and efforts to show that they are in need and distress at a level where they're thinking about these issues. Men tend to use more lethal means and therefore are more likely to die from those efforts. And so it's something about, in some ways, one of the major issues or differences is the types of things that men and women, again, being very broad in general, tend to use to demonstrate their being in that level of distress, that level of pain, that level of concern that we have to take into account.
Anita, what do you want to add to that?
I really absolutely agree with this statement, but I have some, interesting data that we've been seeing. So first, just to reiterate, what Dr. Griffith and Derek said was that yes, the research consistently shows that women are more likely to contemplate suicide, men are more likely to die from suicide. We also see that the means of suicide are very different. Women are more likely to take like pills, and men more likely to use a gun. Well, one is far more likely to result in death, and that speaks to lethality. But we've had some interesting findings from Louisiana recently, where for the first time we are seeing that men are more likely to report that they thought about suicide in the past year relative to women. And that's very new, very different. We know that we've been having just this mental health crisis that it preceded. Many people think about that as really having been incited by COVID, but it preceded COVID. We were already seeing an increase in suicide rates, and it certainly got worse during COVID. But we're continuing to see the effects of this mental health, these mental health concerns. One of the striking findings for me was that our 18 to 29-year-olds, and this is to me tragic, about 16% of them, 18 to 29, have thought about suicide in the past year. Pretty equal for women and men. Once we start looking at 30 to 44-year-olds, it goes from about 16% to 8% of women who have thought about it in the past year. For men, it just stays high, it just stays at that 16%. So this is something that this level of sort of hopelessness, and this is something that, I would defer to hearing what Derek has to say about it, but there is that we're seeing men falling behind in terms of getting their educational opportunities that relative to women. I mentioned the piece about who's going into becoming a physician in med school and law school. Something is happening to men in our society, and it's something that we need to really be focusing on more.
Derek, what would you like to add to that?
No, those are great points. I mean, I think we've seen some of the evidence from folks like Richard Reeves in his book of Boys and Men, where he talks about how the educational system. We tend to think of men. I've gotten in trouble for this before, so I'll try not to do it again today. Of talking about men's essentially general structural advantages in, I'll qualify it and say most areas of society. And where we don't see men being advantaged are in areas like education, as Dr. Raj was mentioning. We see men tend to have higher rates of unemployment. And so the labor market shifts have been something where we've seen men struggle as well. And with the advances and changes that we've had in the ways that we think about family structure, family roles, and particularly the role of provider and how that's evolved over the last 50 to 70 years, that men who define themselves in the context of a family primarily through the role of being provider, that is no longer sort of often their central role. And so we're not as clear about what is our role in a family if it's not to be the provider. And so that has left some feeling a bit, having somewhat of an existential crisis, if you will, about what exactly are we supposed to do in families and so forth. And so it's not something to suggest that we should go backwards, but it is to say that we have to pay more attention to understanding how men are supposed to adapt, evolve, grow in this next phase of our society.
We only have about a minute left. I do want to mention the Suicide and Crisis Lifeline. If you are experiencing suicidal ideation, or if someone you love is, the Suicide and Crisis Lifeline is available. You can call or text 988. And the efficacy of talking to somebody that is backed up by scientific evidence as well. And with just 1 minute left to go, Anita, I'm going to let you have the final word. Do you think that it's useful to really look at this gap to understand the differences that men and women encounter when they seek healthcare and their different health challenges?
I definitely do. And I also think that we've got to be tackling what I'm calling the gender wars, which is that men are feeling like they're not being valued. And I think women are feeling at the same time like they're being overburdened. We're seeing a big shift that's going to affect the health. And we need to be looking at this. Gender still matters.
Anita, thank you so much for talking with me.
Thank you so much.
Anita Raj is Executive Director of the Newcomb Institute and Professor of Public Health at Tulane University. Derek Griffith, thank you so much for talking with me.
It's been a pleasure.
Derek Griffith is a professor of health equity and population health at the University of Pennsylvania and chair of Global Action on Men's Health. We are minding the gender gap. On the next episode of Unsettled, last year, the internet exploded when someone posed this question to women. Would you rather be alone in the woods with a man or a bear? In reality, the greatest risks to women are not strangers or bears. Women are more likely to be victims of domestic abuse or sexual assault at the hands of someone they know or love. Men are more likely to be murdered. We'll talk about safety, risk, and violence prevention. Unsettled is a production of IPR News. Our producers are Caitlin Troutman, Samantha McIntosh, and Danny Gear. Our digital producer is Natalie Dunlap. We had production assistance from Maddie Willis. Our executive producer is Katherine Perkins, and we get technical support from IPR Broadcast Operations. I'm Charity Nebbe.